It seems very clear that our health system in the US appears trapped by administrative complexities that continue to become more and more complicated by the day. It would be very easy to apply a recent Fortune quote from Amazon CEO Andy Jassy, who said, "Modern healthcare is just kind of nutty, and future generations will look back on this time wondering what we were thinking." So true on so many levels. The administrative dogma is worse than ever, and there's no end in sight. It's all wrapped around years of layered processes and procedures that increase administrative time and expense. Imagine laying a foundation and discovering that the foundation is really not suitable for the purpose. So what do? Bolt on more processes and procedures akin to the Rube Goldberg machine model. How did we get to this administrative nightmare? One that the bureaucracies and major healthcare business players love, but everyone else despises. Providers, consumers, you name it. Let's find out by digging into the foundation of the problem, the system for reimbursement, or as it's been referred to over the years, healthcare's dirty little secret no one knows about, the coding systems. For the sake of time, and to not bore our viewers, we're just going to stay mostly focused on the ICD, or International Classification of Diseases, with less emphasis on the CPT, or Current Procedural Terminology System. Two systems out of several at play in healthcare. Just the mere fact that we're mentioning multiple systems used for reimbursement should provide an immediate red flag to our viewers. E&M, MSDRG, APRDRG, APC, HCC, SNOMED, and more. With that, we remain focused on the foundational system for this video. The systems used for reimbursement had the original intention of reporting and tracking disease, but since the 1980s have functioned in a dual role, one for tracking disease. The presumption was, and continues to this day, touted as an effective goal, and one that is the instrument required for healthcare reimbursement, which seems to be spanning globally on the administrative side. The historical reality is the International Classification of Diseases for reimbursement was not the intended purpose. Report diseases. It was never supposed to be utilized for payment or the transfer of money. But insurers, stakeholders, and the government saw a classification system that was assumed to have standardizing, reproducible characteristics. While the use may look like a process that can be repeated, what we see in the real world is farther from that assumption than ever. The premise we're about to make is irrefutable, and we will show a very fundamental example, which is at the core of the problem. So here it is. An important date to keep in mind, October 1st, 2015. The Department of Health and Human Services mandated that all entities covered by the Health Insurance Portability and Accountability Act, or HIPAA, must transition to a new set of codes for electronic healthcare transactions in the form of the International Classification of Diseases, 10th Revision, Clinical Modification, and the International Classification of Diseases, 10th Revision, Procedure Coding System. Why? The decision was based on three factors. 1. Not enough specificity. 2. Catch up to the rest of the world, which is using some form of ICD-10. And 3. Too many unspecified codes. We can debunk each one of these. The ICD and CPT systems today, simply put, offer up too many choices. Even with the help of AI technology that taps into highly subjective aspects of diagnosing diseases, these systems continue to fail for their current intended standardization purposes. So what do we have? A system that's incredibly bureaucratic, constantly changing layered rules, has poor accuracy and precision in disease reporting and audit review. It's a system that's time-consuming. It's a system caught in administrative dogma. A system that's plagued with inconsistent reporting and inconsistent critiquing. And most importantly, it's a system that has no answer key, making it impossible to standardize. We will touch on some of these attributes we've just laid out. Why are there constant changes exploited by the insurers, CMS, etc., to slow down the process rather than making it more effective and efficient from a reimbursement position? It's all about the money. But more than that, even if we look at the system of reimbursement with a positive lens, we see very clearly that human inconsistencies are in play at all levels of the process of reimbursement. With that, let's take a long, hard look at a 2011 internal company research abstract that was enhanced recently to show more comparatives between ICD-9 and ICD-10. Column A displays the ICD-9 code and column G displays the descriptions according to the ICD-9 coding system, or corpus. Column E is the number of codes that were used repeatedly in each medical record by manual coders during 30 days of coding. Column C shows the expansion of selections for the ICD-10 coding system. For example, line number 8 has an ICD-9 code of 780.79, and there are now 4 choices of other malaise and fatigue to choose from in the ICD-10 coding system. Column B is the ICD-10 equivalent, also known in the healthcare coding industry as the crosswalk. Column D highlights that the ICD-10 coding system never removed unspecified as part of the diagnosis from the ICD-9 coding system, and in fact makes the decision process difficult and discourages unspecified diagnoses in a reimbursement submission. To the right of the spreadsheet, you see the important information header where we did the analysis. First, let's look at the ICD-9 coding system and the ICD-10 coding system comparatively, so we know exactly what kinds of systems we're dealing with. Look here. The ICD-9 coding system has approximately 7,500 diagnostic codes, whereas the ICD-10 system has approximately 72,500. It's very important to emphasize that diagnostic list of codes for the US is very similar to other ICD-10 designated systems used in other countries such as Canada, which is ICD-10-CA, and Australia, ICD-10-AM. While there are not too many differences globally to the diagnostic systems, there are drastic differences to how the US created its own ICD-10 procedural system, a topic we'll touch on later. So for diagnostic codes, we went from roughly 7,500 choices to roughly 72,500, almost a tenfold increase in the amount of choices in the current ICD-10 system. For procedure codes, the amount of codes in ICD-9 versus ICD-10 parallels the diagnosis systems, 7,500 versus 72,500. Can we draw any simple theoretics from this already? Yes. Too many options that go beyond human recall and processing, and we'll expand on this beyond theory just by saying that more choices makes for an environment that slows down the process even with technology assistance. We'll cover more on this a bit later. Suffice to say, we can already see that the new coding system has failed in elimination of unspecified diagnoses. Just look at column D. Is that even possible for correct recording from a clinical perspective? Absolutely not. Sometimes you just don't know with more specificity about something like malaise and fatigue. But more than that, in the process of patient care, in the beginning of the encounter, you just can't know where the origins are more specifically coming from. Yet this is completely missed when the rules from the stakeholders demand more specificity on the submissions for reimbursement. Remember what the goal is through the care encounters. Treat the patient, use all expertise and effort to discover the source of the malaise and fatigue. There are many other examples of how most, if not all, the unspecified diagnoses are essential in the process and easily explained from a clinical perspective. So why the push from the stakeholders to rid the coding systems of this unspecified classification? The answer? Money. It's easy to simplify and not reimburse for something that's not specific enough, and use that as an excuse for payment denial, even though that is part of the clinical process of diagnosis. We sidetracked a bit, so let's look at the mechanical aspects we discovered regarding the coding analysis. Over a 30-day period, manual coders who read through the medical documentation and assigned diagnosis and procedure codes to a patient chart for the primary purpose of reimbursement only used 2,657 codes out of roughly 17,000 choices. Of the 2,657 codes, 387 of them were used only once. 198 were selected twice, 158 were selected 3 times, 109 were used 4 times, and so on. The pattern indicated that coders focused on the top 616 choices at least 100 repeated times or more, meaning roughly 2,000 choices were not often used. What information can we draw from this? First, the uselessness of describing disease. Better yet, note the example of one of the one-off codes and descriptions. 315.9, which is an unspecified delay in development according to the published ICD-9 coding system, or with ICD-10, the equivalency codes of F81.9, which is developmental disorder of scholastic skills, unspecified, or F89, unspecified disorder of psychological development. So there we are, unspecified disease states actually expanded from ICD-9 to ICD-10. Second, the lack of real objective qualification of coders, controlled by two organizations, AHIMA and AAPC, whose underlying purpose as organizations is membership dues, along with its own certification, to grow and build membership in order to keep its constituency employed. These organizations are embraced by CMS and other payers, by the way, not just providers. AHIMA's mission statement is confounding, as it is neither focused in any way on the patient simply because it's never involved with patient care, nor is that its central focus. The role of its constituency is to code for reimbursement as part of the revenue cycle for healthcare. From their About Us statement, the American Health Information Management Association is the leading voice and authority in health information, which is really just the medical record, wherever it is found. Our people work at the intersection of healthcare, technology, and business. While our patients don't often, really never, rarely if ever, see us, we see our patients in a way no other healthcare professional does. That is because the AHIMA certified professionals ensure that sensitive health stories or information get coded from providers or payer reviewers and remain accurate, accessible, protected, and complete at all times. If it didn't remain protected, it would violate HIPAA and patient confidentiality, a seemingly absurd statement, as anyone in healthcare must adhere to patient confidentiality. At least the AAPC has a much less confounding About Us statement, where the only thing we can question is their education and credentialing. AAPC is the nation's largest education and credentialing organization for medical coders, billers, auditors, practice managers, documentation specialists, compliance officers, and revenue cycle managers. All members of AAPC agree to abide by the AAPC Code of Ethics, which ensures high levels of professionalism, integrity, and ethical behavior. The ICD-10 procedural corpus is the most confused and confounded system that is not globally recognized as equivalent in other countries. The fact that the ICD-10 procedural coding system was developed through an awarded contract by 3M raises serious conflicts of interest concerns, especially when 3M's Health Information System's primary business for profit is in coding and health information management for both providers and payers. So let's get this straight. We entrusted a private sector business, 3M, to create the current procedural coding system known as ICD-10 PCS. Do we not see serious conflicts of interest right out of the gate? Never mind that the procedural coding system is riddled with bureaucracy and ineffectiveness, and is continually supplemented by the CPT system developed by the AMA, but more importantly is continually ridiculed at the grassroots level by providers, coders, and others involved in the day-to-day process. Was this project even put out to bid? Yet there's never been a call out on this contract with CMS whatsoever. We may go on about this in the future. Suffice to say that ICD-10, with its lack of objectivity and its construction with little to no origins from the clinical side of disease reporting, has only added to the administrative dogma in healthcare reimbursement. Another example, grassroots care hitting home. In the spring of last year, the spouse of one of AMI's principals went to the gynecologist for her annual checkup, but also because the spouse discovered fattiness on the lower left side of her breast. The gyno dismissed this as anything serious, but said, "You're due for your mammography, so let's do an ultrasound as we always do annually, due to dense breast tissue." That was performed 2 weeks later. Here's an excerpt from the mammogram ultrasound report. Immediately, we can see that there is an irregular mass in the left breast. The ICD-10 code that matches that, well, sort of, is N63, or unspecified lump in the left breast, and again, the diagnostic tools, mainly the mammo and ultrasound, can't provide any more accurate specificity than that. That's reality. Under the impression, and based on guidelines, the word suggestive does not confirm a diagnosis, and is often a target of potential denials. To counter, The overall diagnostic process has not gotten to the point of an actual diagnosis. A biopsy was ordered as we continue through the diagnostic evolution of this personal case, and you'll note the comments to the right in red, specifically that there is no ICD-10 PCS or procedure code for the biopsy. To get around this, radiology providers must supplement the documented procedure with another coding system, CPT, as it is described in red, and according to the AMA guidelines, the CPT code for this procedure is 19083, ultrasound biopsy. In the next picture, we're showing the use of an unspecified ICD-10 code again, C50.912, malignant neoplasm of unspecified. There still is not enough forensic information yet for a more specific diagnosis. In addition, there is no clear way to match the documented diagnosis of invasive ductal carcinoma. Site 2 on the right breast matched fairly well, and what that means is that coders could probably pre-produce that match. Again, the excerpt of this is from the provider, the radiologist at this point. These are his patient encounter notes from the EMR. All these procedures, along with the diagnosis suggestions, are required for pre-authorization for the patient if insured, and if approved by the insurance carrier, it is covered and paid for at some difficult to understand level, typically significantly lower than what gets submitted. However, if there is a denial or if the patient does not go through that preliminary process of pre-authorization, then the patient can get stuck for the expense of many thousands of dollars for each procedure in the process. In this particular case, it was Medicare, CMS, and thankfully everything was approved, so the process continued. We all must remember that there is a person behind this, and the anxiety and stress level of where it was heading can only be described as overwhelming. The next report is right from the pathology/generic testing of the biopsy, and while coders will argue that there's a tumor registry for the classification of this, again, no ICD-10 code that covers the diagnostic findings. Frankly, coders would have a devil of a time classifying these results, but this is all now under the oncology lens. Now this excerpt is the most important one, drafted by the oncologist. Notice here, and to the point, there is no diagnosis code in ICD-10 for triple-negative breast cancer. This cancer classification is not so unique as it accounts for somewhere between 10 to 15% of breast cancers diagnosed. The simple definition of triple-negative breast cancer is a cancer does not present with estrogen or progesterone, nor does it show positive for the HER2 protein. It would do the world a great service if celebrities who are unfortunate to have a diagnosis could better describe the kind of cancer they are dealing with. This helps the masses to better understand that there are many forms of the disease under the overall category of breast cancer, as an example, and with that, different treatments and protocols for each of these forms. So that this hits home, it should be clear there are real people behind these medical records, and this can't be understated. The stress of the process, the inaccuracies of the process, and administrative pitfalls, which go well beyond what we've presented here. But it comes down to what's really important, and that is the goal of the care you see above: curative. Let's move on. Here's another point. To further rubber stamp how horrible the ICD-10 coding system is, here are examples from the ICD-10 coding system with its 155,000 choices. Feel free to use this link to see more ridiculous codes from the ICD-10 corpus. V90.27XA. Drowning in submersion due to falling or jumping from burning water skis. Initial encounter. V95.42XA. Forced landing of spacecraft injuring occupant. Initial encounter. W56.09XA. Contact with dolphin. So what are our conclusions? Artificial intelligence, or AI, will not solve this problem for quickening processing without continued degradation of care practices already overwhelming the practitioners. Too much effort on the physician administrative side, specifically too much emphasis on the EMR mechanics and pull-down menus as a source repository administratively. This was mentioned during the recent Capitol Hill hearings by HCA and others. Too much control by the stakeholders, CMS and payers, and large company silos and stakeholders, causing more layering, specifically equating to time to process encounters. Time spent with a patient and non-administratively equates to better care. So what are the cures? Create 2 systems. One more clinically based for tracking disease states, one more general with less choices for administrative reimbursement that must be reproducible. We've created a simple, pragmatic example. Simplified coding system for administrative reimbursement. Here are just the superficial steps to create a simplified system. 1. Call on a reasonably sized group of physician providers covering every medical specialty. Have them use their expertise to generate a set of numerical codes for diagnosis for use in that specialty. The CPT procedural system can work, but the choices must be reduced. This can be done by prioritizing the procedure list from CPT. The goal, easier identification of illness for reimbursement. 2. Once a consensus in a specialty is achieved, have it tested by a sizable open sample amount of providers in that specialty for reproducible results. 3. Negotiate pricing with CMS and the insurers for each code. There will need to be some impartial group that mediates the pricing. 4. Agree to the time governance and value it based on consensus and mediation. Time is money. 5. Use SNOMED CT on the clinical side. And then the question on the clinical side is SNOMED CT the answer clinically? Its reporting characteristics are well functioning, but the point of this simplified system is that there can be very good ways to solve the overbloated healthcare crisis. But like anything, the stakeholders and businesses would never advocate for the simplified change. You know why: money. But it is possible. Other countries have a much less bloated administrative system, and it can be done without the imprint of socialized medicine, a term people use to thwart administrative change. But for us proposing this, who are we? We're just a small entity. Lots of exposure and experience, but not even a cog in the wheel. If you like this video, please subscribe to our channel and stay tuned for some more exciting content in the series.